Facial nerve palsy. Most common cause of facial nerve palsy is Bell's palsy. There is two types of lesion. If there is a lower motor lesion, then there will be ipsilateral complete facial palsy, and when there is a upper motor neuron lesion, there is a contralateral complete facial palsy. The etiology is idiopathic. It is related to the Ramsay-Hunt syndrome, which is herpes zoster oticus. It is a triad of lower motor neuron facial palsy plus vesicular rashes in external ear plus otalgia, and the prognosis is very poor for this syndrome. The 70% of Bell's palsy are completely recover, but 15% of Bell's palsy are incomplete to recover. The treatment of Bell's palsy is using steroid prednisolone 1 mg per kg per day, antiviral drugs like acyclovir 800 mg 5 times a day for 5 days, and this only be used within the 72 hours. Eye protection, we use the artificial teardrops, wear goggles, avoid sunny areas and avoid windy areas, and pad the eye in night time and tape it so that there is no dryness in the eye and allergens which can lead to the redness of the eye. Facial physiotherapy can also be given. The treatment of steroid, eye protection and physiotherapy can continue after the 7 days also, but the antiviral should be stopped, and after 2 weeks the steroid should be tapered down and then stop. Electrophysiological nerve testing, if there is no much damage, then electrophysiotherapy can be used, and if there is a bad prognosis, then surgery is the method of treatment of choice due to the labyrinthine compression of the facial nerve. Post-therapeutic neuralgia, it is a nerve pain due to damage caused by the varicella zoster virus or herpes virus. The risk factors are the advancing stage, site of the involvement of the nerve, and severe pain and rash. Diagnostic tests are not specific. There is no specific test for post-therapeutic neuralgia, but there is a viral culture and immunofluorescence staining and antibody measurement can be done for the diagnostic purposes. And for the treatment, there is antiviral agents, analgesics, topical local anesthetics, and corticosteroid ointment can be used. CSOM, chronic suppurative otitis media, also known as chronic otitis media. The types of CSOM is tubotympanic disease and eticoantral disease. Both of them because of the perforation, but the part of the tympanic membrane is different. As in the tubotympanic disease, there is a pars tensa perforation, and in the eticoantral disease, there is a pars flaccida perforation. In tubotympanic disease, there is a conductive hearing loss within having a airborne conduction gap of 10 to 40 decibels, and there is a ear discharge of mucopurulent discharge, profuse, maybe foul smelling or non-foul smelling, continuous or intermittent. The central perforation can be can be in any quadrant: first quadrant, second quadrant, third quadrant, and fourth quadrant. And for the treatment, we will do the antibiotic therapy for discharge and tympanoplasty, constituting laryngoplasty plus repair of fossicle. This is the treatment of choice. Traumatic perforation and disease perforation can be seen in the chronic otitis media. Traumatic perforation, the tympanic membrane is irregular, rough margin, and having a blood clot around the perforation. In disease perforation, there is circular and kidney shaped margins and the smooth margins, and in TB we see the sieve like perforation, multiple perforation in the tympanic membrane. There is 6 types of tympanoplasty. In tympanoplasty type 1 is a simple tympanoplasty. With most common used graft is temporalis fascia, and in type 2 tympanoplasty there is a meringoplasty plus ossiculoplasty due to the ossicles erosion. In type 3, there is a tympanoplasty plus meringostapediopexy, and in fourth tympanoplasty, there is a graft is kept on the round window. And on the type 5, which is which is no longer been used. And type 6 tympanoplasty is there is a graft placed over on the oval window. Aticoantral disease consists of a cholesteatoma, which is also called as keratoma, and there is the abnormal place of the keratinized stratified squamous epithelium. The types can be congenital, acquired. Acquired one is the primary and secondary. Congenital, which is there is epithelium is trapped inside during or before formation of the middle ear cleft, and acquired is the epithelium goes into the middle ear cleft after birth. And secondary is lead to because of the perforation. There is a secondary cholesteatoma. Most common site for primary acquired cholesteatoma formation is Prusak space. Prusak space are located in the epitympanum. The clinical features are conductive hearing loss, when scanty, purulent, foul-smelling, blood-stained discharge. For the management, we do the Purton audiometry and HRCT on temporal bone. For treatment, we do the modified radical mastoidectomy, and modified radical mastoidectomy is basically to preserve the conducting apparatus of the ear. The complication of CSOM is ossicular chain erosion, and there is intracranial, extracranial, and intratemporal and extratemporal complications are also there. In intracranial, the complications are meningitis, extradural abscess, subdural abscess, brain abscess, sigmoid lateral sinus thrombosis. And in the intratemporal complication, there is a ossicular chain erosion, which leads to conductive hearing loss, facial nerve palsy, labyrinthitis, labyrinthine fistula, and petrositis. And extratemporal complications are the subperiosteal abscess, basal abscess, which is at the sternocleidomastoid muscle, and Luke abscess, which is on the external auditory canal, zygomatic abscess, and Cetilian abscess. Otosclerosis. In otosclerosis, there is an uncontrolled bone changes into a spongy bone, which is an unorganized bone. In this, there is an engulfment of the stapes foot plate, which causes no vibration and decrease in the hearing. It is also autosomal dominant. Increased incidence in the pregnancy, most commonly in the female, most commonly at the age of 20 to 30 years. Bilateral hearing loss can be seen. Tympanic membrane, there is a SWOT sign, which is flamingo pink color. And in pure tone audiometry, there is a conducting hearing loss up to the 60 decibels. And there is two type of notch, Cahart or boiler notch has been seen. Cahart notch is dip present at 2000 Hz in bone conduction seen, and boiler notch, there is a dip at 4000 Hz in bone conduction has been seen. In impedance audiometry, there is AS curve seen, and stapedial reflex was absent. Stapedial reflex is absent in the otosclerosis. The treatment we do the stapedectomy or stapedotomy. In stapedotomy is the treatment of choice. We made a hole in a stapes foot plate and anchored with piston. Sinusitis is the inflammation of the sinuses. Acute rhinosinusitis is the most common causative agent is rhinovirus, and the treatment is symptomatic. Acute bacterial rhinosinusitis most common cause is Streptococcus pneumonia, and most common sinus involved in it is maxillary sinus, and the treatment is antibiotics. And chronic rhinosinusitis is more than 12 weeks. It's more than 12 weeks, and the most common causative agent is Staph aureus. And the management is done by the culture directed antibiotics, nasal decongestants, and after if this treatment is not responding, then we can do the FES. FES is functional endoscopic sinus surgery. And for the allergic rhinosinusitis, the most common allergen is carpet dust or a household mite. Most commonly, it is seen in the urban high socio-economic status people. The intermittent symptoms are less than 4 days per week or less than 4 weeks, and persistent symptoms are more than 4 days per week or more than 4 weeks. On examination, we can see the lethargy, allergic or atopic faces, and there is an allergic Schiner, which is also known as Denner-Morgan lines, and allergic salute, which is a nasal crease, and pale appearance of the turbinate, and nasal mucosa is hypertrophied, and it can be confirmed by the skin prick test, in which we use the histamine as a positive control and normal saline as a negative control. And nasal allergen challenge, this is provocative and gold standard test, but nowadays it not being used. and the treatment is done by the steroid intranasal spray like budesonide. And vasomotor rhinosinusitis is increase in the parasympathetic discharge due to the median nerve involvement, and this is non-allergic and non-infective. And for the treatment, we use the anticholinergic spray, that is ipratropium spray. And for the gold standard, we can do the neurectomy of the median nerve. Then there is atrophic rhinosinusitis, which is called angina, which the causative agent is Klebsiella ozinii. Most commonly seen in a young female with poor socio-economic status, with with the iron deficiency and with the multivitamin deficiency, more commonly the vitamin D. And in this, there is a epithelium change, that is a pseudo-stratified ciliated columnar epithelium is changed by the squamous epithelium. And most common complaint observed is the nasal obstruction with the crust formation, foul smell, and anosmia. And for the treatment, we use the alkaline nasal duffing, which soften the crust and Klebsiella can't grow further. And 25% glucose in glycerin, which nourishes the columnar cells. Antibiotics, multivitamin, estrogen spray, which increase the blood flow. And for the surgery, we use the Young's operation, which is alternative closure of the nasal cavity for a period of 6 months. And modified Young's operation, we spare the ears by 1 to 3 mm of hole in the nasal ears. Nasal polyps, AC polyps and ethmoidal polyps. AC is the enterocornal polyps. It starts from the maxillary antrum. It is single, large, unilateral, and grows posteriorly towards the cornea. And child associated with infection, and most commonly unilateral obstruction has been seen. Then it can be further lead to the bilateral obstruction. And in ethmoidal polyps, there is the ethmoidal. It starts from the ethmoidal ear cells, and it is small, multiple, bilateral, and most commonly associated with adults with allergy. And there is a bilateral nasal obstruction. The pathophysiology of polyp is a prolapsed sinus mucosa with no nerve supply, no blood supply, and pale glistening polyps is being seen. And for the treatment, we do the FES, functional endoscopic sinus surgery, and for investigation we do the non-contrast CT scan. Rhinosporidiosis, most commonly caused by the Rhinosporidium sebarii. It is the lower aquatic protozoa, and most commonly seen in the people of southern eastern coast of India, Sri Lanka, Bangladesh, and rural population having a pond bathing leads to the infection of this nose. And there is a strawberry granuloma and nasal obstruction, and it can be confirmed by the biopsy and histopathological examination. In histopathological examination, there is a multiple thick-walled sporangia, and drug of choice is amphotericin B or Dapsone. And for surgical treatment, we can give the laser excision and base electrocautery.